Good morning and welcome. Welcome to the Texas Primary Care Consortium's 2023 Policy Priorities webinar, Advancing Primary Care during the 88th Legislative Session. We're so excited to see so many new names and faces and to welcome our friends of longstanding the Primary Care Consortium to this webinar. And on behalf of our team, we are so encouraged that there are so many of you that believe, like we do, that primary care is a common good, and it is really the prescription for a healthier Texas. Next slide, please. So I'm Sue Bornstein. I am the Executive Director of the Texas Medical Home Initiative and co-lead of the Texas Primary Care Consortium. Also on the webinar faculty are Ankit Sangwi. Ankit is the Executive Director of the Texas Health Institute and my co-lead for the Texas Primary Care Consortium. And Larry Gonzalez. Larry is our legislative consultant to the Primary Care Consortium. Next slide, please. So just a brief overview of today's agenda. We're going to really make the case for why the state's primary care system is vital for healthy Texans. We are going to learn about the Texas Primary Care Consortium's 2023 policy priorities and understand their role in advancing health in Texas. And finally, understand the Texas legislature's policy agenda for primary care and the bills that could affect you in 2023. Next slide, please. So many of you know about the Primary Care Consortium, but for those of you that do not, it's a pleasure to introduce this organization. The Texas Primary Care Consortium is, as far as we're aware, the only statewide collaborative initiative with a mission to advance equitable, comprehensive, and sustainable primary care for all Texans. The consortium is co-led by the Texas Medical Home Initiative and the Texas Health Institute. Next slide, please. Well, how do we do our work? We use a combination of collective action and network-based approach. We lead with the following framework. We educate. Part of what we're doing here today is educating. One of our centerpieces of the consortium is our annual Primary Care Summit. We will tell you at the end about our 11th statewide Primary Care Consortium that'll be held this fall. We expand our knowledge base by sharing best practices, such as a webinar, such as evidence reports, the lessons that we and others have learned, and also tools. We activate. We facilitate opportunities to build and strengthen lasting partnerships for shared and sustainable impact. And finally, we transform. We create spaces for dialogue and action to generate a shift in the healthcare system through policy and system change initiatives. Next slide, please. We could not do this work without our very, very generous supporters. And you can see here the list of our partners. Again, these partners are critical to this work, and we really could not do it without them. So we thank you. Next slide, please. I also want to thank our team. We have a phenomenal team. They work really hard. They work really smart. They're very creative. They're all very committed to our mission and our vision. And it's really a delight to work with all of them. Next slide, please. Well, let's talk about primary care. Why primary care? So primary care accounts for 48% of provider office visits every year, and it influences up to 90% of the total healthcare costs through referrals, testing, procedures, and hospitalizations. But there's a disconnect here. And even though primary care influences up to 90% of healthcare spending, primary care spending on primary care only accounts for 5 to 7% of total healthcare spending. So you can see that our influence is significant. However, our support, our funding, our capitalization, our sustainability is really minimal compared to the impact that we have. And we need to change this. We really do. One of the things that we are happy about is the all payer claims database that was approved and created last legislative session. So we can really say at some point with more certainty how much is spent in Texas on primary care. We know that the 5 to 7% is really a national average. So we really don't know how much is spent in Texas, and we need to find out. Next slide, please. Again, why primary care? The pandemic has really had a devastating effect on a lot of households, as you're aware. Medical debt in Texas is 23%. It's really significant versus 14% nationally. Tragically, 15% of Texans went without care because of cost versus 10% nationally. This next statistic is really sobering, and that is that almost 30%, 27% of Texans do not have a primary care practitioner. Why is this important? It's important because we know that people who have and can identify and can access a usual source of care tend to be healthier. And also, Texas ranks last in the country in access and affordability, and 40 out of 51 in avoidable hospital use and cost. And I would say to you that one of the things we know about primary care is that good primary care, accessible primary care can really avoid hospital use. Things like asthma exacerbations can be taken care of in a primary care office. Things like congestive heart failure can be taken care of a primary care office instead of a hospital if primary care is available. Next slide, please. And all of you know this statistic all too well. 5.2 million Texans are uninsured. Simply is not acceptable, and it's not sustainable. This is the most in the nation by far, 2 times the national average. And again, why is this important? Well, I think it's pretty clear that if people that don't have insurance tend to access care less frequently. And when they do access care, it typically is in a more costly setting, like an emergency department rather than a primary care office. This is not evenly distributed. Okay, there are definite health equity issues at play here. 27% of Hispanic Texans are uninsured compared to 12% of non-Hispanic white Texans and 18% of non-Hispanic Black Texans. And also, geographically, this is not equally distributed. So we know that in some places along the Texas-Mexico border, the rates of uninsured exceed 30%. And sadly, almost 12% of Texas children are uninsured compared to only 5.4% nationally. Next slide, please. We in Texas have a particular challenge with rural healthcare. And even though Texas is home to some of the largest cities in the country, Houston, Dallas, San Antonio, Austin, we actually have more Texans, more of our residents live in rural areas than in any other state. 3.8, almost 4 million Texans live in rural areas. And accessing healthcare for these people is even more challenging than for typically folks that live in the cities or the suburbs. 32 out of 254 counties have no primary care practitioner. 75 counties have no physician assistant, and 28 counties have neither. Let that sink in for a minute. These are counties that do not have any reliable health care. And what does this mean? This means if you're a pregnant woman and you're having problems with your pregnancy or you're about to deliver, you're going to have trouble accessing the proper care. If you're in a motor vehicle collision in a distant area, same thing if you have a stroke and you live in a county where there's not health care. So these are very real, really challenges to people's health care. And also, we know that Texas leads the country in rural hospital closures. So primary care access is a challenge in all over our state, but we're particularly sensitive to the challenges faced by our rural Texans. Next slide, please. Thank you. And so at this point, I will turn the microphone over to Ankit.
Thank you. So again, good morning, everyone. Thank you for joining us for this webinar discussing policy priorities for primary care during the 88th Texas Legislative Session. As mentioned, I'm Ankit Sanghvi. I'm the Executive Director with Texas Health Institute and co-lead for the consortium. Really excited to be joining today and encouraged with those who have joined us and for doing your part in powering primary care for all of Texas. Before I get into sharing our policy priorities for this ongoing legislative session, I thought it was important for us to also contextualize why the focus on policy, but also the approach we wanted to take as we were seeking to make primary care primary during this current session. As Sue mentioned, like our work has been identified our strategy of educating, activating, and transforming, and as some of this data and the current realities of our primary care and health in Texas has been contextualized so well by Sue, it became clear to us that this is a multifactorial, complex set of issues that a one-size-fits-all approach will not work. Also, part of it is some systemic challenges that really will require policy as the founding strategy for a sustainable and a true effective solution. So with that as part of like the guiding process and thought, about a couple of years ago, especially with the pandemic really shedding a light on the vulnerability of our primary care system, where going into the pandemic, there was a lot of push and efforts around transformation. It became clear to us within the first year of the pandemic that in part it was also a survival work. So with that as an impetus and the guiding process, we started kind of looking at developing our policy strategy and how we wanted to sustainably and strategically strengthen primary care in Texas in service of our mission of health of all Texans. So about going through a rigorous planning process, engaging with our steering committee and partners across the board, about last fall with strategic support from Episcopal Health Foundation and St. David's Foundation, last summer, we were able to pull together a statewide consensus panel to help us make primary care primary, not during this current session, but as part of our work and our pursuit moving forward. With the idea that we wanted to advance bipartisan smart public policy that will truly help us identify and pursue solutions that increase access for all Texans, especially our most underserved populations and communities, strategically and sustainably find and advance strategies that reduce cost, and more importantly, improve health outcomes at the individual level, but also at population level. So again, grateful for the support from the Episcopal Health Foundation and St. David's Foundation. And as I mentioned, to help us do this work and make sure that our policy priorities were reflective of the multifaceted nature of the system, was encompassing all the different perspectives that makes up our primary care system. We convened the statewide consensus panel, and I won't go through the names, but I just want to recognize each and every individual on this list for their time, commitment, and leadership in helping us identify the priorities and really help put together a framework that was representative of every voice and perspective that makes up our primary care system, including providers, payers, purchasers, and patients, but also making sure that we were taking a foundation building approach as we seek to identify our policy priorities, not just for this session, but how can we create a foundation that will allow us to build upon in the long run, again, to achieve true systemic change. So thank you to all of our consensus panel members. I do see on our participant list, a few of you have joined and really appreciate your leadership in this work. Next slide, please. So again, given the systemic and chronic nature of our challenges, what this has also been, what this journey for us has also been has been both gratifying and encouraging, because when you bring like-minded and committed individuals in a room, this policy priorities or the package of priorities we have really underscores that collaboration and consensus building is possible. And we were pleased with the final outcome, given the systemic nature. We really organized our policy priorities, and as we have been pursuing it during this current session, they are organized into the 3 buckets of increasing access to care, promoting value-based payment, and strengthening primary care. If I may, for those of you in the world of primary care, this really takes an approach of increasing access to care is really like looking at and tackling some of our most acute challenges that we face. Really highlighted some of the data points that underscore the need to address the challenges with uninsured, but also access, especially in rural areas. But we clearly know that the current system is not going to truly help us or does not incentivize true value. And as part of ensuring that we are doing our part in creating the right environment and ensuring the right systems and policies are in place that encourage and support this transition to value-based payment systems, both from a care delivery as well as financing. Our second bucket is really looking at this from a management lens, if I may say, again, drawing a parallel to a primary care, the science of primary care and serving our patients. And then lastly, really looking at the prevention model, and that's where our impetus or focus on a long-term strategy that can truly strengthen our primary care system, not just from a workforce standpoint, but also from an infrastructure and the innovations or systems that need to grow along. Again, next slide, please. What I'll do first is I'll go through each one of these buckets and identify, again, as I said, truly grateful that we were able to identify several different policy options that, again, reflect our idea and an impetus that we wanted to make sure that we were truly identifying and advising priorities or solutions that were systemic in nature and were benefiting all stakeholders within the primary care spectrum. Again, our uninsured problem is a complex problem, and this list of priorities do underscore that fact. And again, I'll go through. So the first most important for us is we have to identify and advance solutions that reduce the number of uninsured Texans. And what we have is a couple of options for our legislature to consider. It's not just looking at expanding coverage. We are encouraged and do want to find ways that we can pursue expansion of provide 1 year of Medicaid and CHIP postpartum. But really, we see a lot of value and this low-hanging fruit opportunity in investing and ensuring there are resources available to educate and connect Texans to coverage by increasing funding for our healthcare navigators and community organizations that can assist eligible Texans to apply for Medicaid, CHIP, or federal market-based premium subsidies. The second strategy within this broader bucket of access to care is to strengthen access to primary care with a primary impetus on our most underserved or hard-to-reach communities, and really want to build upon the strong foundation and work or the value that our network of federally qualified health centers have brought into play, and making sure that there is continued attention and investment in strengthening the network of FQHCs within Texas, especially with a focus on our underserved populations or hard-to-reach communities. Simultaneously, we are encouraged and we do support in part the Texas Health and Human Services request to increase evaluation and management rates that will help us sustain the current network of providers that serve patients, especially on Medicaid and other forms of public insurance. The third element, again, many of you on this webinar are familiar that we have about 400,000 kids in Texas that are eligible yet uninsured. And part of that has to do that our Medicaid or the sign up and renewal system or infrastructure needs to be upgraded, but also need to have the right capacity to help support this enrollment. And we duly support all efforts or identify the value in all efforts that simplify signups and renewals through our Medicaid system, which includes ensuring that there is adequate staffing of the eligibility system. There is increased automation and use of reliable data sources to increase the rate of data-driven renewals. We want to support the idea of temporary waivers to renew Medicaid using verified SNAP data and a modernized website or mobile application to make it easier for Texans to complete their critical steps as part of the renewal and sign-up processes. And last but not the least, as a silver lining of the pandemic was telehealth in terms of how it has helped bridge gap on access. But as we move forward and with our vision or pursuit of making primary care more comprehensive, equitable, and sustainable, we do want to leverage telehealth as a tool in our toolbox for ensuring care continuum and supporting this idea of comprehensive coordinated primary care. But for that, we need to ensure that the right system and infrastructure is in place, and want to continue encouraging or asking our legislative leaders to find ways or identify where opportunities and needs exist to strengthen our infrastructure for telehealth as a tool in our toolbox for access, and also support efforts that lead to interoperability in health information exchange. Move on to the next bucket of promoting value-based payment. Again, this set of policy actions are meant to be more foundation building for the larger environmental system that we will need to facilitate true transformation, both for primary care and healthcare. And really have two sets of buckets or priorities. First is to facilitate coordination and collaboration amongst payers, providers, and purchasers to operate within this environment. Our first priority or ask is to really support the recommendations that have come out of the value-based and quality improvement advisory committee that HHSC has been coordinating or convening for several years now, and implementing the recommendations, specifically giving managed care organizations credit for broader range of work promoting value-based care, moving away from a specific focus on meeting APM targets, revising the current APM reporting tool to collect only needed data in as streamlined format as possible, and having Texas Medicaid endorse a standard primary care health model that MCOs may voluntarily adopt for some providers. Second, we also, as we went through our discussions, identified that there is opportunities to ensure that legal framework and structures support the transition to value-based payment efforts. And as part of that, we support the idea of revising some language in our statute that will allow PPOs to engage in risk-based sharing arrangements with physician groups and vice versa. The second part of the strategy is to really promote, again, this has been part of an evolution, not just in Texas and nationally. And there is not a one-size-fits-all approach. So we truly support the idea of identifying and evaluating innovative solutions that can truly help us track effectiveness and efficiency of the different models that fall within this evolution of prospective payment models. Particularly interested in the idea of a pilot on a non-medical program to reduce healthcare costs that can help us with testing and evaluating the impact of this intervention, again, both from an efficiency and efficacy standpoint. Now move on to the last bucket, which is on strengthening primary care, which I shared earlier is really part of our pursuit to truly achieve systemic change in the long run, and that is sustainable. And to help us get there, we really support the idea, again, encouraged, as Sue mentioned, that last session, our leadership approved the creation of the Texas All-Payer Claims Database. And with that as an amazing resource, we truly have a unique opportunity to truly measure and report our primary care spending across payers, but also across populations by geography, by demographic, and so many other variables that can truly help us appreciate the 5 to 7% spending data point that Sue mentioned, and put that into context across, again, so many different factors to help us really identify what could be those financial strategies that can really help us identify and inform some cost-cutting measures, or if I may say, cost reduction strategies as part of broader healthcare spending. As that data is available, we have seen research has proven, especially some other states have adopted the idea of utilizing data or spending data from APCD or other sources and identifying a target spending goal for their Medicaid programs. And over a 3 to 5 year period, they have seen the investment paying dividends in terms of the cost going down and experiencing broader population health outcomes. So you want to leverage, again, this data to hopefully inform a strategy that can create a primary care spending target for our Medicaid program as an early starting point, and then looking at it across the spectrum. And last but definitely not the least, primary care is really a foundation of a high-performing healthcare system. And really what allows us to do that is our primary care team. And we do know that part of our challenge to access to care is the infrastructure of, or if I may say, the capital investment in infrastructure, but it's also our team or the individuals that make up our primary care team, specifically our physician and nurses. And we do support continued investment or support for increasing resources and opportunities for graduate medical and nursing education. Specifically, given that the Legislative Budget Board in 2015 had developed the Texas State Government Effectiveness and Efficiency Report, while it was encouraging to see some early implementation in the ensuing couple of sessions, we do know that opportunities exist to implement all of the recommendations, again, identified in the Legislative Budget Board report. And we do believe that it takes a really foundation building approach to systematically address workforce related challenges, especially from a demand and supply standpoint. So with that, it's been an honor to again join you all today and share our policy priorities for the upcoming session. But it also became clear to us as we're going through this work that this is the science of primary care, or the policy part of it. But to truly achieve change and get the attention at the legislature, we have to understand or navigate through the politics, but also set realistic expectations, because our legislators do have some choices to make, and wanted to make sure that we had the right resources approach as we, again, hope to be successful during this session and get some wins to, again, have a strong foundation to build upon in this long-term pursuit, which we hope you will join us. And with that, I'm pleased to hand this off to our legislative consultant, the Honorable Larry Gonzalez, to again share his wisdom and his perspective on what opportunities exist in the current session and how do we navigate through the session to ensure that there are wins for primary care as we go through this session. So Larry, on to you, and thank you again for your leadership.
Great, thank you, Ankit. I appreciate it very much. It's exciting to see so many familiar names in the RSVP list. Some of you I haven't had the honor of meeting yet. Some of you I've been working with for 30 years. I want to talk today a little bit about the policy and the political reality of the conversations that we've been having for the last 30 minutes. I have worked in the House, I've worked in the Senate, I've worked for the Attorney General, I've worked for, Lieutenant Governor, across different state agencies. And I will tell you this with authority, every session is different. Every session is different. Every session has its own flavor and feel. This is number 16 for me. So I've seen quite a bit, the mood and the swings of this building. I believe that we do have some opportunities in this unique time. The building is feeling its way toward more success when it comes to health and mental health. The building is looking for some wins, in my opinion, and they're there to be had. There is some financial opportunities, which we'll discuss a little bit later on. But I think the mood as we hear it has been developing quite a bit. Ankit discussed several policy issues earlier. The 6 that are on the screen now are the ones that we've identified that have gotten significant conversation, whether it's Lieutenant Governor, Governor, Speaker, new committee chairs. These 6 are the ones that we really have heard a lot of conversation around. That's why they're on the screen right now. For example, the 12-month postpartum coverage. I guess we're all familiar with what happened last session. I've been saying for months that I think the 12th month postpartum coverage happens this session. Well, and then what happens is the governor talks about that in his speech. So I think we're in an opportunity to make some of these things actually move forward. 6 to 7 weeks into session right now, we see and anticipate these moving for the next 2.5 months. One thing that was exciting for me to see was a select committee on healthcare reform, chaired by Chairman Harless, continue into the legislative session. To me, that's exciting because this committee has worked so hard to create and put together all these ideas from various stakeholders through their interim. And we're going to continue those conversations going forward. We had a great conversation with Chairman Harless yesterday in anticipating kind of what's going forward, to know that we're there to help him and to be his cheerleader on so many of the issues that they're talking about. So it's exciting to see the conversations continuing within that same committee as well. But to the core of this is the policy that we can discuss and navigating the politics that determines which of these can be successful. The state budget, I've been a budget conferee twice, as a lot of you guys know. The state budget is a reflection of the state's priorities every 2 years. You can look at your personal budget, you can look at your business budget, you can look at the state budget. The budget is a reflection of what we choose to prioritize with our funding. There's a lot of conversation about a budget surplus. The hallways are filled with how do you spend this money. I saw one state rep had a press release where he discussed the almost $50 billion surplus. I have spoken with Senate finance members who would tell you that number's probably actually only 3 or 4 billion. The conversation around how much money there is to spend varies greatly. If you walk the halls like we have been the last few weeks, you've also heard that money has been spent several times over, because everybody has their idea for how that money can be spent. Is the money there? Yes. Do we have it more than we have in the past? Absolutely. Is it as much as people think it is? I don't think so. And more importantly, will it be there going forward? So from a budget perspective, from an appropriator perspective, it isn't just the money you have for the 24-25 budget cycle. You have to also contemplate what it's going to look like in 26 and 27 and 28 and 29. So you have to have a big picture, the budget and the budget structure and what ongoing costs are versus singular costs. In the state budget, there are five spending caps that the body has to navigate. There goes some of that money right there. You've also got 14 to 16 billion of that is from the rainy day fund, which the body would have to vote to spend. With that kind of money, I don't know if the body does that. Governor Abbott has spoken at length about property tax relief, and he wants as much as half of the monies available. So you begin to see that the number's probably not 50 billion. I begin to believe Senate Finance when they tell me it's probably 3 or 4. That's where the number comes from. So we begin to navigate all of these incredible programs. Keep in mind the conversation around money to fund them. You can have, and we have always had wonderful conversations around education policy, road infrastructure, healthcare policy, but you have to be able to fund it, and you have to be able to fund it going forward. These are kind of the things that we're having discussed going into it. This effort of what you've seen on these slides today is an effort that will take all of us. A true consortium, people working together. When you get into conversations like this, what you've traditionally seen in my 30 years is the silos of individuals working on their agendas. What I'm suggesting to you here today is that the legislative reality is we need to be in the same boat, rowing in the same direction together to the extent possible, because this will take all of us. This will take all of us in as unified voice to go to that building and express what our budget priorities would be for the health of all of Texas. And I will turn it over. Yeah, that was a great slide there too. The collaborating partners, the speaker has his priorities, and the policy and politics. Those are all the things that we've covered. I look forward to a conversation that is collaborative with our consensus panel, that is cooperative, bringing in friends from different silos into the same to speak with one powerful voice. Sue?
Yes, thank you. Thank you, Larry. Wow, this was great, Larry, and I'll get excellent job and really covered a lot. And I know that we know that's a lot to absorb, but we're just so excited to share with you all that, you know, the things that we've been talking about, working on for the last, well, since the Medical Home Initiative was created in 2008, and since our collaborative really started essentially in 2013 when we started doing our annual summits, and really in earnest in 2018 when we more or less formalized our collaboration. We've done a lot of work, but we also recognize that all the great work that we do, if we don't have policy and we don't have policy priorities to support it in the legislature, we are not going to be able to achieve what we really hope to. And so adding Larry and the consensus panel was phenomenal, and just really a great group of people. Really challenged us, which is wonderful. We want that. But certainly adding Larry to our team has, I would say, upped our game significantly. So we do have a couple of questions, and I wanted to address one of them that came in earlier, and it was about primary care in rural Texas. And Yeah, it is a big challenge. And, I started jotting down a couple of notes about it. And I think, it's pretty clear that this has to be intentional. It's going to require innovation. It's going to require money, right? I mean, because if you think about some of the rural communities that we were talking about, one of the challenges, honestly, is the payer mix. In some of the smaller communities, the less well-resourced communities, people are older. We know that people that live in rural areas, that they tend to be older, they tend to have more chronic health issues, and they tend to be less well insured. And that may sound cold, but it's a reality in terms of organizing medical care. So we always have to think about who's going to pay for this. I think getting physicians and other healthcare professionals to communities is also a challenge. So I think things like loan forgiveness programs that the legislature has done in the past can be very, very helpful. We would need more of that. And we've already talked about telemed and telehealth, and certainly they do have a place. They have a very important place in our rural communities. However, we also know that there are large swaths of Texas that don't have bandwidth for telehealth. And so those are things. I will point out a couple of what I consider to be bright spots in this. And that is, I want to talk about our friend, Dr. Doug Curran, who many of you probably know. Doug is a family physician in Athens, Texas, a true visionary. And in his community in Athens, a lot of challenges for people to access care, and the whole area around their Gun Barrel City and those places. And so Doug and some of his colleagues and friends were able to create a federally qualified health center look-alike. It will be a federally qualified health center in Athens. Now, what's interesting, there's a couple of interesting things about that. One of which is that Doug worked with University of Texas Tyler to get a rural family medicine track at the clinic in the federally qualified health center. So, how do you get people engaged in rural healthcare where you expose them to it? Now, some of these people are people that have grown up in small towns, but not all of them have. But I think you have to have that kind of exposure. I also think about Texas Tech School of Medicine, particularly the Amarillo campus. They have an accelerated family medicine training track, which has produced good results. It produces excellent, highly qualified, highly motivated family physicians, but it does it a little bit earlier. So to have those kinds of programs are good. University of North Texas Health Science Center has had a rural health institute for a number of years. So again, it's funding, it's also creativity, it's innovation. So it's the payer mix, but it's also getting people there to work. And so I think there's some exciting things, but it clearly is an area that there's a tremendous amount of need for. And I don't know if Larry or Ankit want to add to that.
I think again, so I mean, well covered, and I will 100% agree that so it's a complex problem. So it's not like fixing one component will solve it in its true essence. But just for building upon what you had shared and bringing it close to policy, again, I would like to re-emphasize that part of it is to make it sustainable or even viable for PCPs to exist and operate, not just in rural, but in some of not the more densely populated parts of our state. I do see tremendous value and wisdom and truly encouraged with HHSC identifying and requesting in their LAR an increase for evaluation and management rates. It's a drop in the bucket, but it's a sustainable or a more critical one than one of us can really express. So I do think that if we're able to see that through and the legislature is supportive of that, we'll be solving one part of the problem. But I do agree with you. So that it's part of it is policy, and there are a number of things we should be talking about in that regard. Loan forgiveness, you already mentioned, but it's also outside of policy. There are some other opportunities, which I can appreciate your wisdom there. So Larry, anything else to add?
The appropriator in me always goes back to costs, right? You always look at, because look, I was a young staffer when we were doing loan forgiveness and we were encouraging this kind of work. So it is not the first time we've seen that, but it has, they will put a fiscal note on it, and it's going to cost something. Sue's exactly right when you talk about a broadband, right? Broadband. I think one thing that came from COVID for state government in general is we learn where the gaps are, right? COVID forced our hand to realize that the state has significant technology infrastructure gaps. To the extent that the state has earmarked $200 million toward technology infrastructure improvements, right? So we know it's real. But particularly, Sue, the question of that rural broadband also touches education, right?
Right.
And so it extends beyond just the medical. And this is why I talk about a consortium, because if we're going to talk about broadband access to rural, that's where we grab our rural education friends, to come with us and have the conversation. This is when I speak about together as a team, one unified voice, that forever you would see a conversation being, hey, telehealth needs more broadband. And over here, a different meeting, you'd have education saying higher ed, public ed needs more broadband. What it should be is all of us together discussing the need for broadband, right? It's those kind of changes, I think, or more overt efforts to make the case as a group.
That's a great point. Of course, we have it for oil wells, right? Because oil wells have to report into the state every day. But that's Texas. Okay. So now a couple of people have asked what I think is the proverbial elephant in the room question, and that is about Medicaid expansion. And so, Larry, to you, Larry, what is your take on the likelihood, the approach, of Medicaid expansion in this state?
Okay,
that's an easy one, right?
So I feel like that Saturday Night Live skit with the Debbie Downer where she's like wah wah. The political reality is it's just not going to happen, right? And I think you have to work around that. We can agree or disagree on the policy of what expansion even looks like, because I've heard a lot of definitions for expansion, right, across the political spectrum, right? But the word expansion in of itself is one of those terms that causes some immediate angst, right? And so part of the conversation is talking about these things in a way that people just don't dig in automatically, okay? But the reality is that expansion is a very, very tough topic in that building. There are some things out there that I've seen, that I've read across all kinds of policy areas that do begin to touch on that issue. But I see that virtually impossible in this building, to get that done. When I was on appropriations, we'd had these conversations about, expansion, what it looks like. And my good friend, Mayor of Houston at the time, Sylvester Turner, would talk at length about expansion of Medicaid. And the conversation revolved around, but so what are the rules, right? What are the federal rules around this expansion? What does it look like? Is it 90-10? Is it 80-20, 70-30? What's the monetary split between the feds and the state? Well, it's easy to see. You can start out at 90-10 and kind of work its way down as the rules are currently written. So the question is, for a lot of members, is, well, what happens when the rules change, right? What happens if our 90-10, 10 from the state, 90 to the feds, flips on us or changes dramatically, right? And so there's a lot of hesitation with that. And it's a conversation, man, I was on appropriations, 3 sessions we had that conversation. So yeah, I wouldn't count on it, Sue.
Yeah, I knew that. It's going to be the answer, but it's important.
Thanks for the question.
No, it's important for other people to hear. But I do think, there has been talk, and if you think about the targeted populations, and that has seemed to sort of have a little bit more palatability, I guess I would say, in the current legislative session. For example, the 12 months postpartum, right? I mean, that is essentially a targeted expansion. Now, we don't call it that because we want it to happen. And I love somebody in the chat has already said, well, what about 24 months? My answer to that is, listen, let's start. Don't let
take your 12.
Yeah, don't let perfect be the enemy of good, as I say. It's
Right.
like if this, and we were talking about this yesterday in our team meeting, I think this 12-month postpartum policy is really emblematic of what it can take to get a good bill passed. And this is at least the third session that this has been happening. And so I do think that, fingers crossed, Larry is right. But the point of saying that, and Larry said this, Ankit said this too, this is a long game. Yeah, will there be some short-term wins? I hope so. But we also know that even if it's a good idea, even if it's a great idea, it can take time to really turn people's minds and find the funding. But so I think targeted, maybe whether it's kids or it's, aged, blind, disabled, dual eligibles, or populations like that, it is possible, I think. But yeah, that's the answer. So we have a couple of people have asked this, and I think this is really an important question in our state in particular. What about healthcare for undocumented residents? And this is a major challenge. And as far as I'm aware, there's no organized effort to look at that. But Larry or Ankit, do you have any thoughts about that?
Larry, do you want to go first?
I mean, unfortunately, we know what happens. They walk into a very expensive emergency room, right? And they get the care, but at a very expensive price, or they don't get the care at all. And they continue to get sick, and things progress very quickly, worse for them going forward, and they get more sick. And then you deal with much more serious issues 12 months later. For sure. And look, this is the population that I'm very familiar with. Growing up where I grew up and how I grew up, I am very, very familiar with this population. And I've seen it my entire life. And I've seen the struggle in the healthcare part of it, the education part of it, the banking part of it, right? I mean, it extends across so many different policy areas. It's a tough one. Yeah. It's a tough one for sure. And I just don't know what an answer is in 2023. I didn't know what the answer was in 17 and 15 and 13 when I served either. It is a continuous, very, very tough conversation. When you see what's happening even today, right? I think it was 14 when the first big trains were coming in into our southern border, the masses of people. It's a really tough political conversation, and it has been for a while, Sue. And this is one of those ones that just the policy and political reality is a hard conversation.
It is, and you're right, and but I'm glad that I'm very glad that people are bringing it up, because it's clearly important, and it's one of those, I know that there are some hospital systems, for example, this is not about primary care at all. This is once you're way past the need for you always need it, past primary care intervention. For example, dialysis. Right. So, right. There's emergency criteria for dialysis, but by the time you need that, you're pretty darn sick. And so I think a few hospital systems have said, okay, listen, we're going to make this a possibility. We're going to find a way to fund hemodialysis, because again, what happens, these people, they end up in the emergency department. They are really sick, much more resource intensive. So that's not the best example, because again, that's already an in-stage kind of an illness. We certainly would hope that we could prevent end-stage renal disease and the need for dialysis. But my point of saying that is that some hospital systems and even counties have said, okay, listen, this is an issue. We need to figure out how to do better for these people, but also for us. And so kind of taking a proactive, that is not the standard of care. And it's a big, big challenge. And as Larry, I think appropriately says, the political will is not there yet. My personal belief is we do need comprehensive immigration reform. Nationally, that has not happened, but it's a great question. Also, go ahead.
Again, just in part, piggyback, and again, how much of this applies to us? We have had this conversation. How much of the problems we talk about is a healthcare problem, is a financial problem, is a political problem, and the list could go on. And I think Larry hit the nail on it, that yes, I think it is close to home than we think. But at the same time, the larger problem is beyond the walls or confines of healthcare. And when I talk about undocumented immigrants or other populations as well, it's been a conversation that many of, again, on this webinar and even internally within our own team and groups we have talked about is we have ways to go. When I really think about the right solution, it's about strengthening our safety net system. And it's not just looking at FQHCs, but our charity clinics
Right.
have played a fundamental role as well. And I think it's this broadening our understanding of what makes up our safety net system, what rather it should be, and what solutions or supports are needed to ensure that it continues to evolve, but also has the right supports to survive and sustain itself, is a larger conversation. Again, how it comes close to us during this session, I don't really, I wouldn't frame it that is a solution 2023 for ensuring that we are doing our part of solving the problem, especially as it relates to providing care for undocumented immigrants. But again, if we can strengthen our FQHCs or investment in FQHCs as part of broadening that community access point, I think it's a step in that direction. But we still need to have this larger conversation on truly what is our safety net system.
I'll add two things to that. So, the other conversation we had is, okay, so it costs money. So one conversation is, who's paying? Is it the state? Is it charitable works? Is it charitable organizations? Is it groups that are set up as the federal government, right? See, all these questions where perhaps the answer is it isn't just the government, right? And so how do you look at those other kind of organizations that can help out? The other thing I'll add is, to let you guys behind the curtain a little bit, the other conversation we've had is, how do we strengthen the areas, help strengthen, teach, educate the areas from which they're coming? I went to Mexico. I went to Mexico City. I went to Puebla. We talked the infrastructure of what can Texas do to help Mexico help that population. I did some work back in the day with presidential nomination, helping kind of walk through our dreamer conversation, that particular population. And so Mitt Romney had some ideas, and so we were helping him think through all that stuff as well, right? Yeah. So I think the question posed is that last reality around a lot of policy topics that get us there. And how many of the other policy topics can we get to and talk about that helps us with that?
Yeah.
Not easy, though. Not easy.
No, it's not. But it's a great conversation. And I see our friend Glenn from Athens spoke up. Thank you, Glenn. And we need to put you all center stage at some point to explain how you all have done what you've done in Athens. Glenn is the CEO of the clinic there. And so a couple of other questions I think need to be addressed. One is about the role of advanced practice registered nurses, APRNs. And yes, we strongly believe Primary Care Consortium in the value of team-based care. We do, for lots and lots of reasons. So absolutely, in our worldview, having nurse practitioners, PAs as part of the team moving forward is absolutely essential to this. And I don't think that we do necessarily a great job with that now. And I think that there's ways that we could do things differently and better. And again, I mentioned we have to be innovative and we have to be creative. The challenges that we have in the state, in our country, but the challenges in our state are pretty significant, but also so is our resolve. And that's one thing I think all of us know about Texans. Okay, we see problems and we really do want to solve them. A couple people, so there was a question about what specific primary care bills have been filed this session. Ankit, or did you want to answer that?
Yeah, I'm happy to get us started. So of the 6 that Larry identified in his first slide, we have a few there. And just to make sure that you receive the most up-to-date information, I would encourage you to sign up for our newsletter or reach out to one of us, myself, Sue, or one of our team members. We can get you added. Like as we go through this session, our hope is to send bi-weekly updates on policy updates as it relates to bill filings, hearings, and so on and so forth. But given the winter freeze break and just with the nominations of the committee or formations coming into play about a couple of weeks ago, we still are waiting. We do know that bills have drafts or are in the process of being filed, but really at this point in time, we only have a couple of them that we know are filed and we have a bill number for, and a few more that we are anticipating within the next week and a half. But one that we do know is the 12 months postpartum coverage. We'll definitely be working and sharing about that. And then there is one that we are waiting on the bill number, is on the pilot to address non-medical drivers of health. And then there is a bill on the House side, HB 1073, for the value-based payment reform, but we are waiting for the bill filing or number on the Senate, the companion bill on the Senate side, which we do know is underway as well. And I could say the same for the other items, but to ensure that you are the most updated and can help support the cause here, I highly encourage you to reach out to one of us so that we can get you added to the listserv. And as we have more updates on bill filings, numbers, hearings, votes, we hope to continue to keep you informed and hopefully engage you as we navigate through the session.
Thank you. We have time for a couple more questions, and these are interesting ones too. One of them was, could a school-based health program meet some of the needs of rural communities? I think that's really an interesting idea. And certainly it's not just rural communities. I think there's examples in this state and other places where, in fact, yes, schools can do that. Think about schools in a rural place in particular. They're probably, other than the maybe hospital, the biggest employer, yeah, I think that's again, when creativity and innovation is what it's going to take to solve this. But I like that idea a lot. I really do. And what was the last one I was going to ask about? Federally qualified health centers absolutely are partners in this. There's no question about it. And Anka talked about the safety net, and the FQHCs are certainly a big part of that, but there's others. There are certainly charitable clinics, and I didn't mean to give them short shrift, especially in terms of taking care of undocumented individuals, because they really do a lot of that. And our safety net is frayed, but it would be a whole lot more fragile if it weren't for them. And Dr. Crow, any discussion of Office of Primary Care in the executive branch? Okay, I think based on the NASM report on primary care, that is certainly one of the things that we talked about. I think that could be an aspirational goal for us. Again, who's in charge? Essentially, who's in charge of primary care? Who's gathering data? Who's helping set policy? And we don't really have that right now. So I do think that that's an aspirational goal. So these are great questions. Really good questions. Can I have the last slide, please? Thank you. Okay, drum roll, virtual drum roll here. So we're very excited to announce the 11th annual Texas Primary Care Consortium Summit. It's going to be in Houston this year. And we think there's going to be a lot of synergy and a lot of engagement in Houston. And we're really, really excited about it. The tagline, creating stronger primary care together for a healthier Texas. So we're very excited. You'll be hearing more about this in the near future. And we thank you for participating today, and thank you for your interest and your support. And we look forward to further opportunities to learn from you and to work with you to improve the health of all Texans. So with that, any closing remarks, Anka or Larry?
Just thank you again for joining us. Thank you for the work that you do to advance primary care and health of all Texans. And we hope you will continue to join us, support us as we seek to make primary care primary, not just during the session, but as in our onward pursuit. So thank you for your leadership and what you do. Larry, on to you.
I echo all of that. Again, going back to my first comment, I was so thrilled to see the number of people who had signed up and the diversity of fields and different lenses that they look at this problem through. And I can't tell you from being in the building 32 years how encouraging it is to see so many people looking at the same issue now and wanting to get to the core of this and make some changes. So it is a consortium, and I'm so glad you guys are here.